Assalamu alaikum and welcome to the lecture on drug-induced kidney diseases. The material for this chapter has been taken and adapted from Pharmacotherapy Handbook by Joseph T. DePirio in Internet Sources. I am Sheikh Mohammed, lecturer in the Department of Pharmaceutics, Faculty of Pharmacy, University of Sindh. This is the outline of the lecture, in which firstly we will be having introduction to the drug-induced kidney diseases. Then we will be discussing its epidemiology. Then drug-induced kidney structural and functional alterations, and we will be going into the details of these structural and functional alterations. And finally, we will be discussing in detail the AMINOGLYCOSIDE nephrotoxicity. The drug-induced nephrotoxicity or drug-induced kidney disease is a common complication as a result of various diagnostic procedures or various therapeutic agents that are used for the treatment of various diseases, and this will result into various of the conditions that may include the changes into the acid base level of the kidney or the urinary tract. There will be maybe changes into the electrolyte levels. There may be sedimentation problems into the urine. The different components of the urine, like that the urea or the blood components, will sediment very rapidly. There may be proteinuria into the urine. Proteins will be present into the excreted urine. There may be presence of the pus into the urine, called as the pyuria, or there may be presence of the blood into the urine, called as the hematuria. In certain other situations, there will be decline into the levels of the glomerular filtration rate, and that will be an indication that the kidney function has declined. In certain other situations, we can determine the renal function by determination of the serum creatinine and the blood urea nitrogen, and that will indicate that whether the kidney is functioning normally or not. And of course, the changes into these serum creatinine or blood urea nitrogen will be because of the certain drugs. Now, most of the times, this problem, the drug-induced nephrotoxicity or drug-induced kidney disease, is uh, treated, or the functioning of the kidney comes to the normal level if the offending agents or the causative agent is removed. However, in certain other situations, the situation may be complicated. So we can call it as the acute renal failure. If the kidney function is recovering, the kidney damage is occurring in about 48 hours, but it is recovering very rapidly when we are removing the causative agents and we are giving the symptomatic treatment. Or if the damage is very much severe, it may go into the end stage renal disease. If we discuss about the epidemiology, it has been observed that the admissions that are made into the hospitals that are coming from the community, 20% of those patients are suffering from acute kidney injuries, and these are related to the drugs. And the patients who are even admitted into the hospitals, about 7% of them may suffer the acute kidney injury, and mostly this acute kidney injury is occurring into the critically ill patients, and 20 to 30% of the patients that are in the hospital may go through at some level of the drug induced kidney injury, and this is makes a significant level of the morbidity and mortality. And of these cases of the acute kidney injury that are occurring into the hospital, 25% of them are related to the use of the certain drugs. Here are the list of the structural and functional alterations that can occur in drug-induced kidney injury, and these include tubular epithelial cell damage, hemodynamically mediated kidney injury, obstructive nephropathy, glomerular disease, and tubulointerstitial disease. These structural and functional alterations are discussed and detailed into the further slides. The first of the structural or functional damage that is occurring into the kidneys is the tubular epithelial cell damage. In this, the epithelial cells of the tubules of the kidney are damaged. Now, this may occur due to two problems. Number one is the acute tubular necrosis, and second is the osmotic nephrosis. In the acute tubular necrosis, the cells of the epithelial layer of the tubules are damaged, and it is one of the major cause of the acute kidney injury. It may occur because of the low blood pressure. Because of the low blood pressure, the nutrition will be less available to the tubular epithelial cells. The oxygen will be available less to the tubular epithelial cells, and eventually the cells will be destroyed. In certain other situations, the certain nephrotoxic drugs, by accumulating the toxic amounts of the toxic substances, can damage the tubular epithelial cells. In osmotic nephrosis, the certain drugs are causing decreased level of the fluid inside the cells of the tubules, the upper layer of the tubules, and eventually, because of dryness, the cells are destroyed. So here is the list of drugs that can cause the acute tubular necrosis and osmotic nephrosis. These include the aminoglycoside antibiotics that may cause the acute tubular necrosis, the radiographic contrast media, cisplatin, carboplatin, amphotericin B, cyclosporin, tacrolimus, edifovir, cidofovir, tenofovir. These all can cause the acute tubular necrosis, while the mannitol, dextrane, and intravenous immunoglobulins can cause the osmotic nephrosis by extracting most of the water from the tubular epithelial cells. The next functional problem is the hemodynamically mediated kidney injury. Now, in the kidneys, there are certain mechanisms which maintain the blood flow and blood pressure, and thereby maintaining the intraglomerular capillary hydrostatic pressure, glomerular filtration, and urine output. The afferent and efferent arterial vasoconstriction is mediated by the angiotensin II, while the afferent vasodilation is mediated by the prostaglandins. So, when we are giving the drugs which are inhibiting the angiotensin II, are inhibiting the prostaglandins, these drugs are making the changes into the blood flow and blood pressure into the kidneys, and eventually when sufficient amount of the blood is not reaching into the kidneys, the kidney cells will be damaged. Though the kidneys are one of the smallest organs of the body, but the kidneys are receiving about 25% of the supply of the blood. So if there is any change which is decreasing the supply of the blood into the kidney, this will result into the damage into the kidney cells. So here is the list of the classes of drugs that can cause the drug-induced kidney injury. These include the angiotensin converting enzyme inhibitors, the angiotensin II receptor blockers, the non-steroidal anti-inflammatory drugs, cyclosporine, tacrolimus, and muramumab. These all drugs will cause the changes into the blood supply to the kidneys and cause damage to the kidney cells. Next problem is the obstructive nephropathy. So there are some drugs that will cause obstruction into the flow of urine. After the glomerular filtration, the urine moves to the collecting ducts and it is excreted out through the urethra, though it sometimes is stored into the urinary bladder. So there are some drugs which may cause formation of the stones inside the kidney, and when there is stone formation, the flow of the urine through the bladder and the urethra will be decreased. And there are even certain other drugs which cause changes into the prostate gland, and even with the increased size of the prostate gland, the flow of the urine is obstructed. Now, as a result, when the flow of urine is obstructed, the urine flushes back to the kidneys, and this will result into the toxic metabolites into the kidneys, increase chances of the infection into the kidneys, and eventually the kidney will go into the diseased state. So here are the list of the drugs that can induce the obstructive nephropathy. There are three types of the obstructive nephropathy that can be induced by the drugs. Number one is the intratubular obstruction. These drugs will cause obstruction inside the tubules, and these include the acyclovir, sulfonamides, edenavir, and methotrexate. The nephrolithiasis is the formation of the kidney stones that may include the calcium carbonate stones, and this will be caused by the sulfonamides, trimterene, and edenavir. Last is the nephrocalcinosis, that is the formation of the calcium phosphate stones, and this may be caused by the oral sodium phosphate solution. Next problem with the kidney may be the glomerular disease, in which the glomerular apparatus will be damaged and it will be unable to filter off the blood components for the excretion of the toxic metabolites. And the drugs that can damage the glomerular apparatus include the gold, lithium, NSAID, COX-2 inhibitors, and pimidronate. Next is the tubulointerstitial disease, that is the damage to the kidney tissues by different drugs. This includes the acute allergic interstitial nephritis that may result from the sudden allergic reactions of the drugs and that will damage the kidneys. These include the ciprofloxacin, penicillin, NSAIDs, COX-2 inhibitors, proton pump inhibitors, and loop diuretics. Second is the chronic interstitial nephritis that will result into the after some time of the use of the drugs, and these may include the cyclosporine and lithium. Finally, the papillary necrosis can be caused by the NSAIDs, aspirin, caffeine, and the analgesic drugs. Now we will be discussing in detail the aminoglycoside induced nephrotoxicity. The aminoglycosides are the antibiotics, and one of the commonly reported adverse reaction of this class of the drugs is the nephrotoxicity. Though the aminoglycosides are used into the hospital premises under the supervision of the healthcare professionals, but those patients who are receiving the aminoglycosides, about 5 to 15% of these patients may suffer from the aminoglycoside induced kidney injury. The clinical presentation will be the rise into the serum creatinine and decreased serum creatinine clearance after 6 to 10 days of the therapy, and the patients will be non-oliguric, and there will be about more than 500 ml of the urinary excretion per day, and there will be magnesium wasting up to 10 to 30 milligram. Now, if in a patient aminoglycoside nephrotoxicity has been determined, the prevention will be to the alternative therapy. We can switch the antibiotics to the fluoroquinolones, or we can use the third or fourth generation cephalosporins in this placement. If the switching the drug is not possible, we can go for decreased doses of the aminoglycosides, the doses that will not cause the kidney damage, and we will avoid the use of the other drugs that are also damaging the kidneys. Like the furosemide is also causing the nephrotoxicity, and the aminoglycosides are also causing the nephrotoxicity. So these type of the combinations should be avoided. Uh, and once daily dosing with the aminoglycosides should be used, high dose but once daily dose if used, that will cause less damage to the kidney. So here is the list of potential risk factors that will result into the aminoglycoside nephrotoxicity. They are divided into the three categories. Number one is the related to the aminoglycoside dosing. So if we change or increase into the doses of the aminoglycoside, this will result into the increased chances of the nephrotoxicity. So if large total cumulative dose is given or prolonged therapy is given, it will result into the more chances of the aminoglycoside nephrotoxicity. True concentrations that are exceeding to 2 milligram per liter and recent or previous aminoglycoside therapy will result into the increased chances of the aminoglycoside nephrotoxicity. Next is the related to synergistic nephrotoxicity. If aminoglycosides is given with other agents which are also affecting the kidney function, there will be more chances of the nephrotoxicity. These agents include the cyclosporine, amphotericin B, vancomycin, diuretic, iodinated radiographic contrast agents, and the NSAIDs. The third category is the certain predisposing conditions into the patients that will result into the increased chances of the nephrotoxicity when aminoglycosides are used. This includes the diabetes. If the patient is having diabetes, the diabetes is also affecting the functioning of the kidneys, and the patient is also using the aminoglycosides, there will be more chances of the nephrotoxicity. The other factors include the increased age, poor nutrition, shock, gram-negative bacteremia, liver disease, hypoalbuminemia, obstructive jaundice, dehydration, hypotension, potassium or magnesium deficiencies. Now, if the patient has suffered from the aminoglycoside-induced nephrotoxicity, to manage this patient, we will go for the measurement of the serum creatinine after 2 to 4 days to determine whether the serum creatinine level is coming to the normal level or not. We will determine that the patient's hydration is maintained, and if the serum creatinine is increased by 0.5 milligram per deciliter or more, we will try to discontinue the regimen or revise the regimen so that the serum creatinine level comes to the normal range. And in certain other situations, we may go for the short-term dialysis as well. The radiographic contrast media that are given for the imaging for different investigative purposes are also one of the major factors that cause the kidney injury or the acute kidney injury. So there are some certain interventions that can be made to decrease the chances of the acute kidney injury induced by the contrast media. So into the intervention, there is first about the contrast media. So what changes into the contrast media could be made that will result into the decrease into the toxicity caused by the contrast media. So we can minimize the contrast media volume or the dose. We should use minimum doses of the contrast media that will not damage the kidneys of the patients. The use of the non-iodinated contrast media, uh, studies has shown that if there is more use of the non-iodinated contrast media, there is less chance of the drug-induced diseases or the contrast media-induced kidney diseases. The use of low osmolar contrast media has been also found very effective. If we go for the medications, the use of or the avoidance of the drugs that are causing the nephrotoxicity, like the NSAIDs. If we avoid the use of the NSAIDs along with the contrast media, the chances of the kidney damage will be less again. The administration of the normal saline about 1 ml per kg per hour up to 150 ml per hour pre and post contrast media exposure will result into the less damage to the kidney. The administration of sodium bicarbonate 150 milliequivalent per liter in dextrose 5%. The administration of 3 ml per kg per hour 1 hour prior to contrast exposure then 1 ml per kg per hour for 6 hours after the contrast of the administration of the contrast media result into the less damage to the kidneys. In other situations, the administration of the acetylcysteine in the dose of 600 milligram orally 2 times a day, and that are given 4 days before the administration of the contrast media and 4 days after the administration of the contrast media, has been found very effective in decreasing the contrast media induced nephrotoxicity. In the last column of this table, the grades are given. The A indicates the strength of the recommendation. A is good, B is moderate, and C is poor. That means if there is A into the column, that means for that recommendation more evidences or more research is present, and for the B there are less evidences present, and for the C there are about very poor evidences present for that intervention. So there is no C into this grade table, there is only A and B, and the numbers 1, 2 and 3 shows the R1 for the controlled, 2 for the cohort studies, and 3 for the expert opinion. So again, and to the last column there is no any expert on opinion. These are all the controlled studies and cohort studies that are very evidence based. That means all these recommendations can be used to decrease the contrast induced nephrotoxicity. So this is all about drug induced kidney diseases. Thank you very much for your time.